Okay, ladies and gentlemen, we are live.
Good afternoon and welcome to the Eureka Springs Hospital Commission regular meeting of September 15th, 2025. Let's have a roll call, please.
David Carlisle, Commissioner.
Vivian Smith, Commissioner.
Willie Daniels, Commissioner.
Kate Drar, Secretary.
Sharon Doremus, Commissioner.
Brian Byler, Vice Chair.
Sandy Martin, Chair.
Tiffany Means, CEO.
Cynthia Asbury, CFO.
Jody Edmondson, HR Director. Velvet Schultz, Clinical Nurse Director.
Thank you all. We have a full house, which is great, and welcome back, Vivian. And we want to thank the City Council and the Mayor for renewing Sharon and Willie's commissionships. So thank you for that. I think everybody has had copies of the minutes from our August meeting. I'll give you a second to look over them if you haven't seen them, and then I will entertain a motion to approve.
A motion to approve.
Okay, thank you, Brian and Sharon. Thank you. And then the approval of the agenda for today's meeting. Are there any changes, additions, deletions? If not, I'll take a motion to approve.
Motion to approve.
Thank you, Willie.
Second.
Thank you, David. All in favor?
Aye.
There's no public here, so no public comments. So we will move right into our illustrious CEO report.
Hi, good afternoon, everybody. I just wanted to share with you, as I start out my report, that one of my focuses, multifaceted focuses, is to ensure that we all know where we're going and how we build a stronger future together. That's a platform that I want to kind of stand out on and lead and build and grow together. So as we move into that, I want to address a little bit about the survey that was brought up in the City Council meeting, and then I just want to reiterate to this group that we are going to be doing sometime the first week of October an employee engagement, a Survey Monkey type of gauge, just to see how they feel, where they're at. We don't really want to do a formal approach to that because we've had some new onboarded staff, and that would give a short-term type of feel where we want to build towards long-term. So let's get them in, let's get our roots going, let's get the build going with the team, let's get the pulse of where we're at right now and see if we can have some building blocks to move to the future on that piece. So I think this ensures that the results that we gather are going to be reliable, actionable, and more of a representative approach in the future. So I have looked at the operations and developed a 16-week plan for the operations. During this time, we are going to be financially tight in the last quarter at Eureka Springs. The recommended budget approach that we're going to take is the operational for best practice. It needs to be flexible, cash-based, and expense prioritized budget. What does that mean? The cash flow focused budget is a short-term mode for us. We're going to shift from long-range planning to strict cash management. We're going to forecast weekly, not just monthly, and we'll be looking at cash inflows and outflows. Prioritize essential expenses. This is in payroll, supplies for patient care, utilities, debt service. The second one is a zero-based budgeting approach for the non-essential This will require every department to justify all expenses. Nothing rolls over automatically. We'll cut or defer non-essential purchases, projects, and contracts until the end of this year. We'll reduce any discretionary spending if there's any right now. There's none approved or forecasted in that manner. Labor cost control. Labor is usually 50 to 60% of our hospital costs, and so with that, we're doing an organizational restructuring for long-term cost savings. We're reviewing overtime and agency contract labor use. Velvet is going to report out on that, some great news that we've accomplished in the last 30 days. We'll cross-train staff to maximize flexibility. I'm looking at every role in every department to see if we can expand those roles, and I meet with coworkers, tell me what your job is like. Tell me, based on your job description, is this what you are doing? And if there's opportunities for them to expand and cross-train within the hospital, we'll be looking at those type of things. And then we're just aligning our staff tightly to the census and acuity, which right now we're core staff, we're at the basis, but we'll just continue to monitor that to prevent overtime if we can. A flexible rolling forecast instead of a fixed quarterly budget. We're going to update a rolling forecast. We're going to adjust projections based on revenue collections and census trends. Next is revenue protection. We're going to accelerate billing and collections, focus on improving coding and documentation for maximized reimbursements. We've already shifted to that, and actually in the past week, we've recovered some things in some of our documentation that gives us better opportunity to be able to maximize our reimbursement. And just ensure that there's no revenue leakage. That means denials, underbilling, mischarges. Next is prioritize mission critical services. This ensures budget protects core clinical services and patient safety. And we'll defer expansion or non-critical projects. Again, our labor force management is, we're looking at that weekly. I have a meeting set up with our CFO that we'll be looking at every week. We'll be looking at this agenda and be transparent in that manner, but we are going to move in that. This recommended budget is, again, cash-based, zero-based, and flexible rolling forecast that focuses on short-term actuals, strict labor management, and revenue capture. It is not about long-term growth right now. It's about ending the year on a good note.
Good.
Okay?
Good.
Lastly, I just wanted to share that since May 1 to the end of August, we called back 203 patients. These are patients that we actually got a hold of. We tried to attempt to get a hold of all patients callbacks, but we were not successful in that. But 203 callback patients, and 6 of those, out of those 203, were negative feedbacks, and we tried to do some service recoveries on those patients. But other than that, 197 patients left a positive report.
That's great.
Tiffany,
And what was the
that's-
time frame?
Yeah.
May 1 through August 31st.
Awesome. Tiffany?
Tiffany?
Go ahead. No,
Oh, sure.
Tiffany, what do you ask them when you call them, the patients?
We have a script
You
that we
do?
ask.
Okay.
And with that, we ask about how their care was, if there was anything that they are concerned about. And so we have a few questions that we ask them. And then when that happens, if there is a negative, then that is sent to me right now, and so that I want to do a follow-up again with those patients. But we haven't received a negative one in quite a while. So these were pretty recent. And so I would say in the last 30 days, I haven't received one negative.
Excellent. So involving the weekly, you talk about the budget on a situation. So are you saying that we're going to evaluate weekly our expenditures? Is that, can you kind of Where are you going with the weekly idea?
So, so what we're doing is we're monitoring all of the expenses and the revenue on a weekly basis.
Okay.
So Cynthia and I get together and we go over what does it look like, what did the last 7 days look like, and so we can stay on top a little bit better. Again, this is a short-term
Right.
plan to finish out the year. So when we looked at this operationally, we feel like this is the best plan for us budgeted to go in and look at it in this way.
Okay, awesome.
The other thing is, you know, it's a shame Tiffany's dragged her feet so much since she's been here. But the other thing is looking forward, this also creates that we've been hungry for, that base going into 2026.
Yes.
And if we, you know, her focus is to secure us to the end of the year and then to get some benchmarks. That coupled with the reorganization, coupled with all the other internal operation stuff that they're doing is going to put us in a great shape. You know, and we don't know where we'll wind up at the end of the year. At our budget workshop, I think we all said we may be in a negative position. We don't know, but we've got to keep it flexible. And next year, we're going to have to be flexible as well because there are so many unknowns, you know, that we're going into it. But this is a real strong base and a real strong platform to feed off of. And I think it's a terrific job that you've done internally to develop this plan. Thank you.
I've been used to, I know Cynthia has zero-based budgeting, and I think this will go set like a model platform for us to move into the 2026 with this type of model plan. But for now, this is our plan moving into the last quarter, and let's see how it works by us closely monitoring that and just keeping our expenses in control, you know, where we're having knowledge weekly instead of monthly.
Yeah. Any other questions or
Just
comments?
on the reimbursement side of it, we talked about, you said we've had pretty good success here in the last, I mean, we've seen some pretty good numbers coming back from it, might
I
understand.
mean, with the reimbursement rates, we have, I mean, as far as with insurance and payer types, I mean, we go into a lot of unknowns going into 26 with the payments. And like within our financials, we'll see, I mean, our charge capture and kind of our billable revenue, we did see a decrease in it again in August, but we have mitigated that. We've got brought on a new contract staff member that's just helping build back up that aspect of charge capture, ensuring documentation, ensure we're not got revenue leakage within the charting elements of on the clinical side of that, so we can ensure we're billing out everything that we are able to.
Good, awesome.
That's critical because we had a lot of leakage with that.
That is correct, yes.
Yeah, a lot of leakage. Any other questions or comments?
Just curious, will that make staffing pretty lean across the board, or are you?
We're already at base. When we talk lean, we're already at what I call core staff, what our minimum is according to the rules and regs of REH. We are meeting those guidelines.
We're beating them, right? Is that what you said? We're
What?
meeting them?
Yes.
Meeting those, okay.
Yes, we will not cut short based on those rules and regs.
So that, you meaning attaining a number of core staff that is at the
Right.
the regulation
And
defined?
what we look at is overtime, incremental times, and Velvet's going to talk more about her powerful work that she's done in the last 30 days to reduce contract. So, yeah.
Okay, do you have something?
When would you like for me to ask the questions on the federal rural hospital initiative funding? In my comments at the end, or does it matter to me?
No, we can put them, yeah, let's put them with.
Commissioner comments?
Yeah.
Because they're just questions,
Yeah.
that's all. Okay,
Great,
great. Okay,
great.
thank you.
Got it. Anything else for Tiffany? Or
No, great job.
how do y'all feel about the plan?
Two thumbs up.
Yeah.
Aggressive, we're being very aggressive, and that's w's great. Very aggressive.
And very prudent and
Yep,
conservative.
Yep, absolutely.
Two good adjectives, aggressive and prudent. Yeah, very good.
Anything else, Tiffany?
Thank you.
Thank you. CFO report. Cynthia?
So within this, before we begin, I'll just kind of make statements on that too, kind of following up what Tiffany said. We've continuously to monitor any cost-saving measures within supplies, within just say mostly ER department, kind of the critical supply areas. We've kind of been averaging for the past 90 days about a little over $2,000 a month in supply purchases. That isn't necessarily inclusive of the lab department because those are very unique to their equipment and stuff. But that's been a huge cost-saving measure we've kind of taken on. Velvet kind of led it with myself, the end of June when we went through kind of organizing, getting the supplies critical, pertinent to an ER. What do we need? What do we not need to reorder? This is better option than that as far as cost saving. So we've really kind of cut really well on that cost saving measure of the supplies, but also started stocking supplies that were actually more critical, more needed for the ER department within that. And we are still, it's about $2,000 a month within the supplies. So we're it's a huge cost saving in that. So we're not seeing, the expiration, just the continually kind of waste of money there within that side. So.
Great.
So within, yes. So the financial report here is attached. You'll see the bank account balances past the cover sheet. Remained about the same for the month of, as far as cash inflow and outflow for the month of August within the bank account balances. So the next page is our cost center, revenue by cost center for our service state for August. And you'll see total charges billed out was $760,000 approximately. Kind of what we noted a while ago. We've brought in someone to help us ensure we're not missing any charge capture within the clinical side and documentation. Very quickly identified that we've working to correct that. Tiffany's got a great plan in place with that with Velvet, so we're going to ensure that we are maximizing our reimbursement on all of the patients we see. So very hopeful within that.
Our laboratory looks like it's up.
Yes.
That's great.
Yes.
That's great.
With us being staffed, it really does increase the incrementals on what we're billing out within the staff 24/7 too. So.
And it looks like radiology is also up?
Correct. Yes, we have seen an increase in outpatient referrals for radiology as well. So.
Excellent. Excellent. More referrals.
Yes.
Super.
Next page is going to be our income statement. Again, our outpatient revenue we billed out. Down through there's our adjustments, whether it's contractual, and then some of the other contractual adjustments, which would be our timely filing and no authorization, self-pay courtesy discounts, but then our expenses are down through there. We did have a loss for the month. Kind of within that, I will say we've been onboarding additional staff, bringing them up to par to be able to reduce contracts. You're going to end up having 2 employees you're paying at the same time. So, nothing short of that. We've been working down the AR within that since we have brought payment posting in-house. So we are seeing some of that adjustments hitting in there, more rapid payment posting side of that and kind of cleaning up some of that. So within that. So, and then the next page is just our balance sheet for the month of August as well. So.
And you spent a lot of time, you got the scripts corrected with Cerner?
Correct. We've spent the last, some of them have been broken for over a year, but yes, we've gotten a lot of the scripts working, which does affect our AR report within Oracle Cerner because it's the 835, the transmitted files back in. So it's kind of between our clearinghouse and Oracle, our EHR system, a file goes out and says, bill these claims. Well, then the readback file saying, yes, these claims were billed, has been broken since last September. We just got that fixed last week. Wow. Yes. So, it's been critical things. So that kind of left accounts looking like they were unbilled on the AR, but we've technically had received payments. They had been adjustments. So once they were marked as transmitted, a lot of that kind of hit through to finally was able to kind of clear through. Payments, everything was captured accurately, correctly, but it was more of just that transmission. Moved the claim to billed final status. So that's, within that. So. And then the other thing that you guys will see, you have a copy there. I provided this just for reference so everybody has it. These are our financial collection policies, our self-pay discount policy, along with an information sheet from the collection agency, along with our bad debt guidelines referencing from CMS. These policies have been in place. They are not new. I implemented them in 2022 when I did come on board. That was the initial time because the hospital didn't have them prior to 2022. So with the CFO, we implemented these. We've continued to revise and keep them up to date. So just wanted to provide you guys a copy of those.
I have a question.
Yes, ma'am.
In the coming months, when we're in the black and we've been in the black and that account's going up and up, would we ever be able to have, the only word I can come up with is foundation, but that's not really what I'm wanting to say, but a box of money in the bank for people who are self-pay with no insurance to help them defray some of that cost? Is that something that we could ever think about doing in the future?
So technically, we do have charity care. We do have a charity care application. So when a patient is unable to pay their bill, they are welcome to fill that out, provide the said documentation. Madison Business Office reviews it, presents it to me. We kind of look through what their income is, kind of what their monthly liabilities are. So we do that, and we offer those as charity.
Wow.
Yes,
okay,
yes,
great.
as charity care discounts.
But
And
Cynthia, in that idea, though, if you've got someone self-employed that does not have insurance, but they have financial means, basically, though, we're not going to offer them, like, the old deal was if you went into the hospital and you didn't have insurance, but you wanted to pay the check right then and there, they'd
we
cut
do
you a deal.
have prompt pay discounts, self-pay
Okay.
discounts as well. So like if you pay
Yeah,
at
it's all-
time of service,
So we at least-
that is one of the policies here
Right.
that is included. So it's 30% initially at time of service, and it kind of decreases
Okay.
from there. So
Can that have a sliding, the self-employed folks, can that have a sliding scale aspect also?
there is within here, so like within our thing, if they pay one time it's the 30%, kind of depending if they pay at time of service. And then we kind of have some other adjustments if they pay as well. And then if they do, Able Pays, who we partnered with to do payment plans about a year ago. So they also offer those free, no cost to the patients, payment plans. So they were able to kind of pay out their bill on their schedule, on their time. Again, it's like us billing an insurance, but to the patient, it's a free, no credit check, no obligations, takes less than 5 minutes to sign up, free payment plan to them to ensure they can pay their bill at their leisure, whether that's $5 a month or $50 a month. So that is 100%, and that's free to the patient.
That's incredible.
And we promote that every time on every admission to the patient. So,
And that's interest-free?
yes, ma'am, yes.
Isn't that wonderful? Okay.
Interest-free, no
That's
credit
great, ma'am.
check. I mean, it's,
That's great. Okay, thank you,
Yes.
Cynthia.
You're
That's
welcome.
beautiful.
Can I ask one question about the REH money? So in our financials, the monthly REH money, where does it lay in this?
the monthly
Yeah, I mean,
CMS payment we
right,
receive.
CMS payment, yes.
Yes.
I
so-
apologize. It's been
No,
so
no,
long
no,
since
you're
we-
fine, you're fine. So I have to make sure which one. It is under other operating revenue. So it's in that bucket. That is in there along with our rent
Okay, I
income
see.
and lease payments that we receive. So about middle of the income statement. Sorry, Brian. The fourth,
Not balance sheet, income statement, about middle of the way down.
about the
Okay.
middle there.
Other operating revenue, right there, I see it.
Yes. Yeah.
Got it. Thank you. I'm just
You're
curious
welcome.
where that was at.
Yes.
All right.
Any other questions or comments for Cynthia? No? Jody, I didn't have you on the agenda, but you're there.
My report will be brief. Since May 1 of 2025, we have onboarded 24 staff members new to us. 14 of those are clinical, the other 10 are non-clinical. Just information.
That's great.
24?
Are
24
those,
since May?
24.
Okay, thanks.
are those replacing contracted people?
Yes,
In essence.
some of them are, not all of them, but some of them.
We're making pretty good progress on that and getting more to our own employee base. Velvet.
That's why I have the best part. First of all, last meeting, you all asked me about volume numbers, and that's what you have in front of you. I obviously spend more time counting them than I do printing them, but the trauma dashboard, the second page you see, this is what we report every month for trauma. Some of those are state-driven metrics that we have to keep track of. The rest of it kind of gives us an idea of what our business is, our mechanism of injury, how patients get to us, and how they leave from us. It just gives us an idea of total patient volume, what is total trauma, what's peds, what's geriatric. Not a dashboard really created for you all. I just shared a dashboard we keep on a monthly basis for us. The other one on the top is our hospital dashboard that would just keep track of our volume numbers every month. September MTD is month to date. So that's as of this morning. You see your total volume, observation patients, left without being seen, left without triage, where do they end up, acute care, psychiatric facilities, rehab facilities. We have some MI, heart attack and stroke volumes in there, as well as at the bottom, just the other things we keep related to deaths in the hospital. And we actually had another MI this morning, actually came in with a pretty impressive troponin, just referred to us from a clinic, spent 5 minutes in our building before they got their first EKG and 90 minutes before Lifeline lifted on the back of our pad, hot, kept running. I'm not always crazy about that, but they did keep it running. The pilot and the 2 nurses, or the medic and the 2 nurses came out while the pilots kept it running, grabbed our patient, and off they went. And we're in the cath lab with less than 30 minutes from the time they left us.
Wow.
Yeah, with some significant disease. I can't obviously share that, but yeah, it's a pretty significant save. Yeah, we're super excited about that. And the staff working today, our new staff to us, maybe only been with us a couple of weeks maybe, and they jumped right on that, packaged them up, had everything copied, were on the phone, and that young lady was out the door before we knew it. I was like, yes, that's the way it's supposed to work.
That's awesome.
Yes.
So that's that 90 minutes under the
Correct.
September month.
We'd like to have that a little less, but it was difficult. The presentation wasn't as advertised, as it was a little tough, little communication issue, but yeah, the outcome was outstanding for that individual.
Does anything surprise you, make you happy, or disappoint you about any of these stats?
I'm still a little bit disappointed with our volume. It hits and misses, but honestly, every week I keep track of it up in our office. Every week it's more. It's 10 more, 12 more, 11 more than the week before. EMS is a couple more. So you can see gradual. I feel like we're making headway. I definitely feel like that we do. Our length of stay is down significantly.
And that's a good thing.
Down to 2 hours and 58 minutes, and we were running in the 4 and 5 hours toward the first of the year.
Yeah, yeah. Well, that's great.
Yeah.
I think a lot of it contributes to having lab open 24/7.
Yeah, for sure.
Yep.
It's quicker turnaround.
And great work of the team. It was phenomenal to watch that today, to see the teamwork, the handoff of the patient from the clinical side to the flight crew side was just effortless, like they've done it a million times before. And we got this patient up and going to the cath lab where they needed to be. So very highly impressed with the team, the Velvet's work. We have, are you going to share?
Yeah, I am. I can't hardly stand. I can't even stand. I had to wait to go.
I don't want to bust the bubble.
Our staffing that these ladies have alluded to is we have 3 brand new full-time RNs, 2 part-time RNs, and 2 new paramedics, 1 full-time, 1 part-time. And to give you an idea, the average tenure in these nurses is 15 years, most of them sitting at 30.
Wow.
2 of them live local, and the rest of them about little less than an hour from us. The medics, to give you an idea, one is a retired fire chief, and the other one is a current supervisor for regional for Pafford. And they are loving being in the ER. So that takes out 3 full-time travelers, and we just converted we don't have the paperwork signed yet, but they've committed to take 2 more of our travelers from a traveling contract to become ours. So it'll end up getting rid of 5 travel contracts for us in the next 30 days.
And 2 of them will stay with us, right? Is that what you're saying? 2
yeah, 2 of the travelers. So I asked them all, and 2 have said yes, that they're going to do the 13-week seasonal and then transition into PRN and just keep their schedule. They live, one lives in Rogers, the other in Harrison,
That must mean that it's a very positive work environment, I would think,
I'm
to
trying
have
hard,
travelers say, yeah, I'm going to come back and be full-time.
Yeah, they see change, they like it, they like what they see, and these, ER nurses will tell you, they'll tell you exactly what they think, good or bad. And
can
so
feel
far,
it.
the feedback has been positive for them, but to take out 5 of them in a swoop, it's been a whirlwind, especially for Jody, trying to get everybody onboarded. And I know that Cynthia, she bears with us. Orientation hours are non-productive hours, but you got to get everybody up to speed and make sure everybody's comfortable and they, get all their education, get everybody signed off. I'm not interested in just, historically, we've rolled them in the door, signed their paperwork, the next day they just start. I need to be able to see them. I need all of their background, all the information, everything signed. I don't want to get caught with the state surveyor of not having those things.
I think what's critical about what y'all are doing with the staff is aligning it with what we do.
Yeah.
The paramedics, the EMS folks, and everything else. And that's got to make a difference in the workforce environment because they understand what's happening and they can help educate the rest of the staff that hasn't necessarily been exposed to that.
Right.
I think that's crucial. Those
And
are
of this
really
staff
good decisions.
that we took on, there is 1 TNCC instructor, a class we're required to have, and 3 advanced cardiac life support instructors and 2 BLS instructors.
And TMT, trauma? Mm-hmm. Yeah.
TNCC, trauma, ACLS, and BLS. And I'm not so sure that Jake's not a PALS instructor. I feel like he's a PALS instructor, too.
Excellent.
And that also saves us with sending them to a class, paying for that,
Yes.
class. And so that's a cost savings. Also, just for a comparative, 3 travel contract reductions in a 13-week period is around $56,000 saved. So again, tremendous work to Velvet and Jody interviewing, onboarding, getting them all ready to go. And they're the ones that basically came to us and said, we want to work here. So lots of positives.
Well, according to them, the word's out that it's a cool place to work. Yeah, we're excited about that. That's
We've
better.
never been called a cool place. That's
I
great.
know.
Hey, Velvet, I
Yes,
think
ma'am.
that answered my question, but most of these people applying already have trauma experience,
Yeah,
ER
they're all,
experience.
everybody
Wow.
we hired has TNCC, Trauma Nurse Core Competency.
Okay.
Yeah. And most of them, one of them has a master's degree, has managed ERs, worked trauma centers on the East Coast, retired here. She actually bought a house in Holiday Island and is finishing travel contract. She starts with us the first part of November. The others are from the Cox, Branson, Lampe, Harrison, Omaha area, kind of down through that area. And one of the part-timers is moving here as well for family. So I know. It's exciting.
Spoken like a true nurse.
Yeah. And when you reference the paramedics, Sandy, today as we were watching them load this, like I went down when they announced to clear the helipad, because I'm like, helipad? Why are we clearing it? Like, what's going, I go down there thinking
so
they didn't
fast.
call me and they didn't need me. Like they had everything packaged, they had everything copied, they had the patient on the right monitor, they were headed out the back door, they were clearing the pad. And it was interesting to watch to be able to stand back and watch the nurse and the paramedic, because the paramedic is driven in a very different way. And I know we've talked about this numerous times, but you just have to watch it to understand it. Like he's thinking like the medic he's about to hand to. He gave the report to the medic, unhooked their monitor, hooked his monitor up, unhooked the pump. Like he's just moving and doing it like he's done it 1,000 times. And it was streamlined. And historically, we had people that struggled a little bit with that because they just don't do it very often. And these guys have been doing it and are still doing it, and they're just doing it in a little different pace right in front of us. Yeah, it's very impressive.
That's great. How do you feel about job security?
For me,
Job security.
Tiffany has to talk
Nobody
me off
can
the lid
replace
once in a
you.
while, Sandy, but
Well, that's good leadership to get people in that
yeah,
can
it's
do
just
it
fun to
and-
be that, to see them be excited. I don't have to ask. I went down this morning. They're stocking all the supplies. All the rooms are clean. They're putting blankets in the warmers. Like I didn't go down and say other than good morning, and they're already doing it. It's already done. And historically, that has not been the experience at
Oh,
all.
my hat's off to the 3 of you.
Yeah.
You've all worked together to make it happen. You've allowed them to spend the money to train them. Oh, I mean, No, my hat's off to you. Velvet, incredible job,
Thanks.
Jody.
It's
I'm
exciting.
just-
We still have a lot of work to do. I won't lie to you. You should
Sure.
see my office. It's dreadful, dreadful. But we wanted to start with what mattered the most, was making us clinically sound and make us safe and make us capable and to take care of the patients as fast as we could. And now kind of comes the next steps of all the periphery in a hospital that has gone dormant. You know, the things that we need to get up to speed. And, I mean, we'll get there, but it just takes time.
My hat's off to you, because what it does now for us is it helps us with this budget situation.
Absolutely.
Because we're starting to run such a tight ship of operation-wise, because we got some quality people.
Yeah.
That now we can really look at numbers and start saying, you know what, these are real. This looks reasonable. So my hat's off, because it helps on the whole gambit.
I think it also helps with employee cross-training.
Yeah.
That when they see that and see other professionals and how people are doing, they're going to want some additional training.
And they've asked, Sandy. One of the nurses today is a SANE nurse that works with sexual assault patients, and she said, hey, can I kind of take that on? I was like, absolutely, yes. Yes, take it and run with it for us. But for me to be able to say, hey, can you guys do some chart reviews today? Hey, can you guys do this? And they're like, absolutely, you leave whatever you need us to do. You just leave, and you can hand that off and know that they have skin in the game, because they're no longer not ours.
Well, and that goes to the culture. When they feel like they have ownership, when they feel like they're part of the team, that goes 1,000%, as you well know, because you're the team builder. So, you know.
Yeah.
So thank you for your leadership, and thank you for all yours.
Question.
Yes, ma'am.
So the 72-hour return to ED rate for all cause, do we have a way to break that down in the future related to blood sugar or cardiac or respiratory or incision, opened up, where we stitched it? And I don't need an answer for that right now.
I do look at every one of them to tell you, and I can tell you one of these two, the lady came back in the same day. They tried to get her to stay. She needed to be admitted, and she said no, so she went home. So she returns in less than 72 hours.
That's an interesting category. We wanted you to stay for observation, and you declined.
They said no, but then comes back.
Well, so I can talk to you about this offline in October, about patient education, especially if it's related to blood sugar, either coming back too high or too low, either one, and diet. So I don't know how much latitude we have, but that's something you and I can talk about. I'd love to drill down on that just a little bit if there's, just depending upon what we can, how we're able to intervene and give them helpful hints.
Yeah, but I look at every one of them to see why. If it was something we missed, something they didn't understand. Normally, and the nurses document the reason why, returns because, whatever reason that is.
Yeah, okay.
But as far as tracking, I can give you an idea.
Sure.
About the reason.
And maybe if we find that there's things related to blood sugar, that anybody who comes in, that maybe we can do some teaching or handouts just as prevention, whether they have a PCP or not. You just never know when the seed gets planted that it's just the right time. It'll help turn somebody's life around. So thanks for listening.
I have a question about the returns. Are those billable? We can bill for the returns. It depends on the amount of time or the
typically not, because that's kind of where CMS has a regulation on the
That's what I
returns. If
thought.
you're so it just depends. Yeah.
And that's why it's reported, because we want to make sure on the first visit that we're covering everything, doing all of the education. And again, if that patient chooses to decline, we need to make sure that we have gone through everything that we could to encourage them to stay and let us help them get better or monitor them. But like Cynthia said, it's one of those that, yes, you track it, but we don't get reimbursed for that.
Do we give the PCP feedback if they have one, or how do we, is there a, handoff to the PCP, or that's the patient's responsibility?
Typically, most of the providers, they're kind of alerted and aware that their patient has been in the ER, and then they do request their records so they can schedule the follow-up visit. So.
Okay. Patient usually has to drive that, because I can't call without their permission to tell them, hey, I've seen your patient today. We can say, would you like us to forward, they can ask, forward my information, forward my EKG, forward my labs.
Yes.
That kind of, but they have to initiate that, wanting them to know.
Is that a release that we can have them sign?
It's not automatic. So like
No.
if you're in a bigger health system that has like Epic, or you're in a bigger health system, within their health system, they automatically can see if the patient has been in there. But since we are a standalone, most of the time it has to be the initiation of the patient to say, I would like for my records to be sent to my provider.
But
Are we allowed?
even in the larger network, it doesn't like throw up a flag
No.
and say, hey, your patient was seen today. No. It's there, but it's in record, but they still have to look for it.
Right.
It's not something just like for us. We can't tell them that we saw them today. But
As
they
far
have to
as I know,
No, in the large, like Epic, imagine the clinic, when my physician documents in the clinic and my surgeon documents in the hospital, my surgeon can flip a button and he sees clinic notes. So he sees them all instantly, real time in front of him. And same with the other way. This family care doc can look up and see the surgeon notes, the hospital record. It all is the same record. One is just clinic, one is just hospital, but it's all under the same umbrella. Ours is isolated, but it's HIPAA violation for me to call and say, hey, we've seen your patient today, I'm going to send you. We can negotiate that with the patient, say, would you like us to send it? You sign release, they can sign and we can send whatever they like. They release their records, medical records. They do a med records release.
So we make suggestions to them
Sure.
to communicate.
Vivian's point on continuity of care is well taken, and I'm so glad you brought that up, because it could be a piece of paper that could be part of our admission process to say, do you want us to contact your PCP, yay or nay? And if they say no, then we won't. But if they say yes, and we're allowed to release the information, then, because the patient might feel like crapola when they leave.
Sure.
And like, oh yeah, I'll call him, yeah, and then
Usually,
and then they
Kate, where
don't.
you see it is when they get to their PCP, and they'll call and say, hey, we're requesting records on a patient we're seeing today that you guys seen 2 days ago.
Well, but
And they rarely do it before they leave. They do it once they get there, or they make their appointment for there.
I get that, but we have, having been in the part of the nursing world where there were lots of checks and balances, there were lots of cases when we got graded down when we didn't, with permission, okay, that's a given, but we got graded down when we did not help the patient set up a post-clinic visit within 10 to 14 days. I can't remember what the benchmark was, but anyway, that's continuity of care is big deal, and it might prevent readmission in the future, but good job.
Are we permitted to ask them who their PCP is and have that on the form and say?
You're required to ask them.
That's what I thought.
You're required to ask them.
And so can we have a check there that says, can we send the records to your PCP, or could we throw one step additional?
Why don't we take this back and investigate it with the team to see what we can and cannot do? I don't
might
think
help
we
with
can
some of
really.
these.
I can tell you there are patients that don't want their primary care doc to know. You know what I mean?
Absolutely.
They're worried about upsetting them or offending
would
them.
say no.
I don't want them to not want to see us if they think we're automatically going to send.
That's not where we're coming
So
from.
typically it is,
Good
the
point.
patients schedule their follow-up appointments with whatever doctor, even the local ones, and then they send a request over and saying, hey, Ms. Jones's appointment today or tomorrow, can you send the records? And we absolutely send them. So typically it is driven from the patient scheduling their follow-up appointment, and or some insurances do send notifications to PCP saying, hey, your patient was seen in the ER, because they see us seeing that billable charge. and that's on the physician then to schedule that follow-up appointment. More on a PCP side, not on us from an REH, ER standalone kind of side.
Yeah.
To schedule for continuity care and stuff, that is on the patient and the PCP.
Yeah.
Yeah.
The privacy is really important. I totally get that. Yeah.
Oh, sure.
Yeah.
I can tell you on our outreach dashboard is for us to visit the primary care docs that are here, because I don't know that I know right offhand who takes new patients, who doesn't. Do they take 2 a month, 1 a month? Is it payer driven? I don't know that, but we need to be able to provide our unassigned patients options in this area.
Yes.
And then I have them out of the other areas if no one here will, but I'd like to be able to provide, and it's like I said, it's on our due dashboard, but we need to be able to give them a more local list.
Yeah.
You know, almost like a periphery. Imagine here's some here, here's some here, here's some here, depending on how far out you're willing to go. Or you might have to go before someone can be able to see
We do
you.
have a list down in admission, primary care.
I feel like it's old. The only one I've seen looks older. Is that nice? Can I say that? Older.
I think there's
More
probably a
dates.
stronger need in this county for that
Yeah.
kind of assistance
Yeah.
than
Yes.
certainly Benton or Washington County. Yep. It's good.
Thanks, y'all.
Anything else for Velvet?
Any comments? Yeah, the competence and the synergy that you guys demonstrate is something I couldn't have dreamed of 6 months ago. This is really gratifying to see that we are viable, as anybody can decide viability in REH at this time, and that we're looking good. It's great. Thank you.
Anything else before we go into comments from any of you? Nope. Do you need the commission's support in any way, shape, or form other than what we're providing you?
No, I think my biggest drive right now is that I really appreciate the support of the commission, and I appreciate the support of the council, and I hope that it is with great hope that we all can be united in serving in our community and promoting the hospital in a way that is positive to our community, that has trust and belief that they can come to our hospital and they'll get the best of care. So moving forward, this is something that I really hope to have a close relationship with everybody on.
And that's critical moving forward. And I think what's great about what's happening now is that we are truly 110% focused on hospital business and moving forward, and it's paying off. And we've got great leadership that stays focused with that. The commission has always been focused on it, and I think we've navigated through the distractions. And the more we maintain on that focus and the focus on the community that we serve, I think more success will come. So I appreciate everybody doing that.
Thank you.
Okay. Commissioner comments. David, do you want to add anything else other than what you said?
No, thank you for your service.
Yes, well said. Vivian?
Yeah, thank you, all of you, really. And I think we can't stress enough, like you mentioned, because the lab's open 24/7. I mean, we may know that, but people out in the community may not remember and may be thinking in the past, and all the positive comments and the way we're going forward. I'm hoping that everyone picks up on this. So please keep it up. Keep on reinforcing all the good that you're doing. Thank you.
Willie?
Yeah, I'd just like to say, for me, it's an exciting outlook coming in new on the commission, so I see nothing but great stuff coming. So, great job, everybody.
Okay.
Ditto everything. Y'all are just knocking it out of the park. There's really, words aren't adequate. So I guess my questions, not to be answered today, but for Tiffany, this federal rural hospital initiative funding, where half of it goes to the states, and the second half of it is through grants. I do keep hearing that the grant part we need to get our request in. I don't know if it's December 1st or the end of December, but it's just around the corner. And I'm hoping very much that you have a buddy of a buddy in the governor's office. But with your lengthy ties to Northwest Arkansas, I won't be a bit surprised if you don't already have a buddy that works in the Capitol. So anyway, how do we get the first half of that to Eureka Springs? How many rural hospitals are we competing with in our state for this pile of money? And if there's anything that I can do in the month of October, since I'll be here the full month, please let me know. I can give you my phone number. I'll come up to the hospital and do whatever research you want me to do, or type what you want me to type, or velvet clean out what you want me to clean out.
Kate, it would spare you.
Anyway, so y'all are just amazing. I don't have enough words, so I'll choke up if I talk anymore, so thanks.
Before answering that, let's finish the commissioner comments, and then we'll come back to it. No, it's okay. It's good discussion.
I think that's the reason I re-upped for 5 more years, is because I felt like we were going in a positive way, and I wanted to kind of ride that wave, because David's right. We are going in a positive, it's just exciting. Yeah. And I'm doing a velvet. I'm kind of putting the word out about our ER when I'm down in the park with my dog, that people need to, not hurt themselves and go, but,
Exactly.
But if needed, we're right up there with the best of them.
I need to give you my little package that, hey, it's flu season.
Oh, okay.
If you get it, don't worry.
We'll put those around my dog's neck.
There you go.
People pay more attention to dogs than people sometimes. So you may have a point there. Brian?
It's ditto, of course. You gals know where we stand. We've been with this long enough to see the worst of it and the worst of times, and now looking at things moving forward look really good. But Tiffany, I appreciate the aggressiveness on the budget idea. I appreciate that, because we both know that, and we all know that that's been a real, thorn in the side as far as thoughts out there. And so I think we're moving in the right direction.
You want to address anything to Kate on the rural?
We have a lot of positive opportunity here. I think what we need to do is continue our strategies and efforts in order to be able to maximize the ability for that money to come our way. There's lots of ideas that are floating around in this little head here that I feel like if we go any of those directions, it would be something that would really have somebody that look at us and going, this is the community that needs the dollars here. They see it, that it's needed, it's vital for this community. I had a community member share with me that just last week that said, if our hospital goes away, that is going to be a big detriment to not just Eureka Springs, but to a lot of the surrounding communities, and then what it does to the EMS crew that have to go outside of the area to go to other hospitals, and then what it does is leave a vacancy here in this community not served by EMS. And so we have to be aggressive yet assertive to writing this and getting this all ready to go and be ahead of the game, be the trendsetter of the game. And I think we can do it. It's just going to take a lot of efforts and those efforts are, I appreciate everybody's opinions and thoughts, and they don't have to be like-minded, because sometimes somebody can bring in something from over here on the left side that you never saw. And I think that's what is going to contribute to the success, is putting everybody together, not just me, but I will be the advocate, and I will be there helping push for those funds to come our way.
Has HHS or CMS, has anybody contacted you about the
No,
money?
they have not.
The thing, and I think the December deadline, the thing that confuses me, but keeps coming up, is the first half of that money is evenly distributed to all the states.
Correct.
And it's up to the states to do it. And I think that that's that December 1st deadline. I think that's what that is, because there's, I mean,
That's what we have to find out.
well,
Yep. And
Every-
she's on, it sounds like she's on it.
yeah. And that's where I think that, you know, when we know that's going to hit, whenever it is in 2026, and I think the most current that we've kind of found out is sometime in the spring, they'll release it, is then we need to spend some time with Little Rock and with our friend Bo Ryle at AHA. There are 5 REH hospitals, to answer part of your question. In fact, AHA has a 2025 hospitals by stats report that you see how they're all split out throughout the state. And, you know, so who we're competing with is going to be a state decision in the first half. The second half, from what I understand, and I think you understand, that's when it becomes competitive. And that's when, is that your understanding, Sharon? Yeah. So it's like, you know, where do we go first? You know, apparently we're not responsible for or don't have an opportunity to put in a grant at this point. We have to wait until the state gets the money and the state tells us what to do, because I think that the state is going to set those parameters for distribution. And, you know, that's what I mean by, you know, we need a road trip to Little Rock.
For the first half of the money and the second half, the state decides both? Is that what
No.
you're, just the first half?
The first
The
half.
ones equally distributed, okay.
Yeah, and the second half, and it's still kind of fuzzy, but the second half is the feds are going to lay some parameters. And they've published some of those, but they're careful to say they're not the final ones. And I'm sure they'll go back from lessons learned on the money used with the first half and tighten it. But the list that we've seen has been about accessibility, telehealth. I mean, a lot of the things that Tiffany's working on, fast turnaround care, again, what they're focusing on, we fit right in that lane. You know, that should be pretty good, but there's still so much unknown about it.
Now, have you seen anything where it's a comparison between rural emergency, REH, and just rural inpatient facilities? Have you seen I just figured it was all one lump, one rural period, like less than X many in the county?
Yeah, I haven't seen a definition that tight.
Okay.
But, and, you know, we might ask our reps to come and see if they know anything. That would be Harlan Bro and Bart Hester. And, you know, if you'd like, I can invite them to come and share with what they know at our next workshop in October. But I don't think it doesn't appear that there's anything we can do until...
Influence it for now.
Right. But I think, you know, it's always the strategy to be ready to go.
Yeah.
And that's the thing, is we have to be really strategizing and getting coordinated efforts to make sure that we are ready to go. And it, you know, a lot of it is research, production, statistics, getting all of that's easy to put together, is when you have statistics already there for you, and then doing the research on the other side. So my history has always told me, always keep great records, because you never know when you fall back on those stats, they're already there for you with a few little tweaks. So we'll make those efforts the best that we possibly can and be ready to go.
I think, detail and charts and track records and records like this help.
Absolutely.
Because, I mean, the underlying issue presumably is the need and the ability to deliver that need. We know Madison County has a hole, big hole. When we did our service area map, it was about 55,000 people. That before there's another hospital within average driving range, And I think by keeping track of stats like this, needs, patient identification, all that stuff, we're slowly but surely and consistently and accurately creating that needs analysis that we should shout anyway down in Little Rock.
And it's always good to know what your growth is and in the genres that is growing at, the pace that it's growing. For prime example, how many in the next 5 years is going to be in our 65 and older patient population? It's those type of predictions, so then you can build your case around geriatric care and the need for geriatric care and the increase for geriatric services based on that statistical data. It's those type of things that I have a lot of experience with geriatrics, especially in data collection, but it also helped us get accreditation for a geriatric accreditation based on those stats as well. So it helps you prepare in a lot of ways, and it's knowing your community and what your community needs are based on that.
That ongoing community assessment.
Yeah.
Any other comments? Nope. Okay, and I think I said Bart Hester, and I didn't mean that. I meant Harlan Bro, our rep, and Brian King, our senator. So I wanted to correct that because it was like...
That's a good idea to try to at least get them thinking that hey guys, we're looking at that money.
Yeah.
To get a little bit of in front of those two to know that, hey, we are looking at that money for Eureka Springs.
And they may not know that much yet, but if we ask them, to the workshop, they might find out.
Well, I think the one thing about that, though, is the fact that, you think about where we were, and I'd hate to go looking for this money where we were, but now where we are, to go looking for this money, just like you say, we've got the data to show what we're doing and how powerful that is.
Right.
A lot of these rural hospitals, they may be where we were, but guess what? We're already ahead of the game.
Mm-hmm. And they serve a different market as well.
Yeah.
My comments are a reminder that we have a special meeting and we have invited the City Council to that special meeting, and that is for the 2024 audit. That's September 23rd of this month, 10 a.m. right here at the auditorium. The reason it's a special meeting is because we will be voting to accept the Forvis audit and their recommendations. So there will be a voting meeting on that. Other than that, just what everybody said, I can't say it any better. And I don't think we can repeat it enough. Just thank you, and keep forging forward. And I love the fact of the focus and what we're accomplishing, because it's paying off big time. So appreciate it. And our best wishes to Terry. You want to give a brief update with what happened to Terry in case nobody knows?
I don't know without his permission.
Okay, never mind. He's out of the hospital. Okay. All right. Sorry. Next workshop is October 6th, 2 o'clock here. And next meeting is October 20th, 2 o'clock here. Appreciate all of you. I will entertain a motion to adjourn.
Motion to adjourn.
Thank you.
Second.
Thank you, Dave. All right, we're out of here.